Hi, and welcome to our first ever UK Stroke Forum Deep Dive podcast. I'm Dr. Louise Flanagan. I'm Head of Research at the Stroke Association. I'm joined today by four fantastic guests. I've got Dr. Jackie Benfield, Dr. Lisa Everton, Dr. Steve Green, and Kostas Eleftheridis. I'm going to just introduce you all, if that's okay, with a little blurb that I have. So, Jackie, you're a speech and language therapist, lead for inpatient stroke in Derby, and an honorary assistant professor at the University of Nottingham. Your research focuses on the assessment and rehab of post-stroke swallowing difficulties. You've been a topic expert in the development of NICE and national clinical guidelines for stroke, and along with Lisa, you represent the UK Swallow Research Group, which brings me nicely on to Lisa as a clinical specialist speech and language therapist at Nottingham University Hospital and also an honorary assistant professor at the University of Nottingham, with a special interest in swallowing difficulties and an interest in outcome measures and treatment for swallowing difficulties. Also joining me today is Kostas as a stroke lead dietitian and enteral feeding lead for North Middlesex University Hospital. He represents the British Dietetics Association on the UK Stroke Forum Scientific Committee and recently collaborated with Dr. Angela Madden at the University of Hertfordshire on research focused on the quality of life for stroke patients in the community receiving enteral nutrition. And last but not least, Steve. Steve is a consultant clinical neuropsychologist and lead psychologist for stroke services at the Queen Elizabeth Hospital in Kings Lynn, consultant neuropsychologist in the community stroke services for Lincolnshire Community Health Services. He's the chair of the UK and Ireland Stroke Psychologist Network and represents the British Psychological Society on the UKSF. And Steve's doctoral thesis was looking at the evaluation of stroke cognitive screening. Welcome all, and thank you so much for your time today. I'm really excited to hear a little bit more from all of you about your areas of interest and also what you're going to be bringing to the UKSF. Jackie and Lisa, if I could start with you, please. Jackie, would you kick us off with a little bit more about what you're working on at the moment?
Sure, yeah. So I spend some of my time clinically at Derby Hospital with the stroke team there, but I'm also conducting research at the University of Nottingham. I've got a trial running at the moment that's looking at swallow strength and skill training with surface electromyography biofeedback, and we're looking at how feasible it is for NHS clinicians to deliver that intervention, which is quite an intensive swallow kind of exercise-based therapy in acute settings, in acute stroke centres across different trusts in the UK, but also looking at dosage, so how much therapy does more therapy result in better outcomes for patients, and that's to try and help people to, the aim would be to see whether this intervention does help people's swallowing improve, whether they can come off tube feeding, whether they can progress back towards eating more normal diets and fluids. So that's sort of longer term plan, but that's the trial I've got running at the moment, which is soon to be coming to an end. So we'll have to wait to see how the results go with that. So
amazing. And can you tell us a little bit more about that biofeedback? Because that's not something that I'm familiar with, and perhaps some of our viewers might not be either. Can you tell us a little bit more about how that works?
So biofeedback is sort of basically monitoring a bodily function, and giving feedback to patients so that they can adapt that. Swallowing is something that we can't see, we can't really have much control over, so it's very difficult to understand how well we're performing it. Okay. If something goes wrong, we end up coughing or choking or food sticking in our throat, and that becomes but we can't see anything sort of more finer than that. So biofeedback, what particularly I'm using surface electromyography, where we place some electrodes on the muscles that are involved in swallowing, and that feeds back through a device to a laptop where there's a kind of image on the screen that can will show the person when they've swallowed and the timing and the amplitude of their swallow, and that then we can then give them exercises to try and improve the strength of their swallow and improve the the skills to the timing and control of their swallow. In fact, one of the speakers we've got coming to the conference, Professor Maggie Lee Huckabee, she's developed the software that I'm using, and also sort of very much she's going to be talking in the conference around skill versus strength training and the sort of difference or the importance of using skill training and not just strength training. So it's around the things that we do, all of the activities that we do are all about skill as well as the muscle strength in order to do them, and the importance of training using skill exercises rather than just, it's not just about power and force, it's around how well you execute a movement. So that'll be really interesting for the conference for her to be feeding back about her latest research and developments there. So,
do you want to tell us a little bit more about the session at the conference as well? What else might people expect to see at that session?
Yeah, so Lisa and I have put the session together with sort of different people who we have contacts with around the world, who we know are doing research in stroke. So Professor Maggie Lee Huckabee is one of them. Lisa's found new work with
Dr. Brittany Crickler is presenting information on dosage and what dosage we need for exercises. There's not enough evidence, particularly in the area of swallowing, to inform how much exercise you give for how long. This is really important because we know from the SNAP guidelines, it's all about intensity of therapy, and particularly in speech and language, we don't have enough evidence to inform those guidelines. So really looking forward to Dr. Crickler speaking and giving us some information around what is the latest thinking around dosage for exercise-based therapy for swallowing problems.
Yeah.
We've also got Professor David Wright speaking about medicine management in post-stroke dysphagia, which is a very tricky area to navigate. Giving medication safely to people who have swallowing difficulties, it's an ongoing issue. I can see Costas is, nodding. As a dietitian, there's such an overlap between swallowing and maintaining nutrition, keeping people safe with the swallowing. So that's an exciting one we're looking forward to as well.
Yeah. And so the last speaker in our session is Dr. Cornelius-Berner, who from Germany, who have a lab there that looks into post-stroke dysphagia and is going to be looking at the prevalence and consequences of post-stroke dysphagia. So that'll be a really fabulous session with kind of looking at the problem, management of the problem and rehabilitation of the problem. Yeah.
That sounds like a really exciting session. I'm sure there'll be a lot of people looking forward to attending that. Lisa, can I come to you next and just hear a little bit more about your research that you're doing at the moment, please?
Clinically, I work in a acute trust. I carry out video fluoroscopy and fees, which are instrumental assessments of swallowing. So basically, once the therapists have done a bedside clinical exam and they want more information, we look to doing something like a video fluoroscopy, which is an X-ray of the swallow, or fees, which is where you pass a tube through the nose, which is an endoscopic assessment of the swallow. So clinically, sort of that's where I am, what I'm doing at the moment. In terms of my clinical academic work or research, I'm a co-applicant on an acute swallowing trial called FEAST, which is looking at giving pharyngeal electrical stimulation through a modified feeding tube through the nose for people who have swallowing difficulties. And I'm also interested in using FEAST, so the assessment with the tube through the nose, looking at developing some research ideas around diagnosis and assessment in acute stroke survivors.
Okay, thanks, Lisa. And how prevalent are swallowing difficulties following a stroke?
Well, I think if you take a conservative estimate, we're probably saying at least 40% of patients with a first ever stroke will present with dysphagia. That's why we have national swallow screening programs. One of the sort of key roles of our speech and language therapists is to make sure that we're teaching our colleagues and putting in place robust screening programs that our nursing colleagues will be carrying out. So everybody who comes onto the stroke unit should have their swallow assessed by a stroke-trained nurse to identify those swallowing difficulties as soon as possible, so we can prevent any post-stroke complications further down the line, like a chest infection, like worrying about poor nutrition and dehydration.
Yeah. So you nicely mentioned there poor nutrition, which takes me over to Costas very nicely. I'd love to hear a little bit more about your research and what you've got going on at the moment, please, Costas.
Perfect, thank you. So as I mentioned earlier, my name is Kostas. Clinically, I work in an acute stroke unit. So I look after a 30-bedded unit, including 20 dedicated stroke beds. So I provide support to my colleagues across the hospital when it comes to complex cases within stroke or any other neuro case. And as part of my role in the enteral feeding aspect, we are doing some QI projects on looking at the care of tubes and tube aftercare for patients who have had either a gastrostomy placement or an nasogastric tube. And we're looking into seeing what their outcome is, which is more local. On a bigger scale, I'm looking at the reasons for readmission in stroke patients in hospital and seeing whether there's anything preventative. That's more specifically for patients who have long-term feeding tubes, which are gastrostomy tubes, PEGs, as people may have heard. And I'm looking into why these patients get admitted. I did a mini project / audit to identify some potential causes, and we often find that there's people who come in with aspiration pneumonia or some deficiency from a nutrient perspective. So I want to explore a bit more on that. Alongside that, I'm working on looking at the quality of life of stroke patients in the long term. We know that a lot of stroke patients may in the long term not be able to eat or drink either nothing or maybe sometimes a little bit. What you may hear as taste for pleasure. I'm sure the speech therapist can I see some noddings. So what I'm looking into, what I want to find out is basically what impact does this have on their quality of life. From speaking to some patients and carers, we have found that some say that, for example, if they were able to even trial a coffee or a tea down a feeding tube, that would help them with quality of life. We often hear from patients that the type of product we're giving them through the feeding tube can make a difference in their quality of life. For example, we have, from a nutrition perspective, when we give nutrition through a feeding tube, we have what they call the feeds and nutritional supplements. And the difference between the two of them is very often the taste. So some patients say that when they get, for example, a nutritional supplement down their feeding tube instead of a bigger feed that is being administered through a continuous feeding pump over a certain amount of hours, they say that they are able to get some of the taste back. And of course, this is more anecdotal evidence because there's not a lot of evidence to kind of put a lot of recommendations in clinical practice. So I'm looking into doing something more formal with a more representative sample of patients and ultimately try to improve this area in dietetics. When it comes to the UKSF program, we have an amazing team of speakers that will be presenting. We will be looking at the long-term nutritional management of the stroke survivor. Often we see that sometimes patients may do very well in the acute side of things. From a nutrition perspective, we may set them up with a nutrition plan. We may set them up with a long-term feeding tube. But what we find sometimes is when they go back into their communities, their homes, their care homes, because of all the other aspects after a stroke involved with nutrition and both cognitive, communication, and physical impairments, they may struggle a lot to adapt. So we tend to find that patients report losing a lot of weight after being discharged from hospital. And we know that the community services in general are overstretched and the capacity within the NHS is very reduced. So a lot of these patients may not be picked up as quickly as they should have been. And often a lot of patients are either readmitted in hospital, which, as I mentioned earlier, or they may just lose weight, not do very well, and ultimately that will, of course, affect their clinical outcome in the long term, affect the nutritional status. And nutritional status is very important, not only from a physical perspective, but also thinking about malnutrition in general. It does affect psychological well-being, quality of life, being able to function. And when we think in the long-term rehab aspect that is very important for the stroke patient. So we will talk a bit about that. We will also talk about the integrated stroke services and what the role of the dietitian is, some early supported discharge teams and the recent role of the dietitian. We have one of the dietitians who is working within one of these teams who will be coming to present and talk a lot more about that. And we will also look at the evidence of gastrostomy placement and what the evidence is, where the gaps are. So that's all from me.
Amazing. Thank you, Costas. That sounds like a really exciting session to listen to. And Steve, can we hear from you now a little bit about your work and what you're going to be bringing to UKSF?
Yes, of course. Thank you, Louise. So I'm Steve. I'm a neuropsychologist working in Norfolk and in King's Lynn. A little bit of background. I've been the British Psychological Society rep for 2 years now, last year and this year. And what brought me to it was attending conferences, especially local conferences, where we would hear a lot from stroke survivors and through guidelines about the need for psychology and neuropsychology support for people. But alongside that, would quite often in the breaks be asked, what is it exactly you guys do? What is the role of neuropsychologists in stroke? And this is often by people working in stroke services. And I think that's partly because historically there's been so few of us, and we're hoping to work to address that a little bit. So that the opportunity then came up to represent the BPS on the UK Stroke Forum, and my thoughts there were, okay, let's kind of be a bit clearer about what it is that we do and how we do it and where we sit within the MDT. So last year we were fortunate to have a session with several speakers talking about the role we play, the importance of not, I think there's misconceptions a little bit that we're therapists and we just do a little bit of counselling. Obviously our role is far wider than that. Not only are we interested in mood, we're interested in helping people to make sense of and understand cognitive difficulties, how that itself might affect mood, and equally how those things might affect behaviour. So the impact of all of those things on the person's recovery, their engagement with rehab, their engagement with the things that you've been speaking about, as well as quality of life and being able to get back to meaningful activity and valued living and things. So that's kind of what the session was last year, really looking about how we play a role across the pathway and what that role is and how we bring that information together to support the patient, the people around the patient, the MDT and wider support teams. And I think that's well received, and I think it was a good project to put forward. But then there was a lot of feedback about, okay, that's good to know what you do. How do we make it happen? What do we do? And of course, in the current climate, things can be quite difficult. So we've got a session this year. We've been fortunate to be accepted to put forward a roundtable workshop looking at how we can make it happen, what we can do, how we can be creative, how we can work within the MDT, what we can do to support teams to access psychologists and what a good psychology provision would look like, and how we might be able to support the MDT. So we've got some 3 really good speakers. We've got Mark Griffiths from the BPS talking about successful developments of services. We've got Kat Ford talking much more from a research side of things. She's at the UEA talking about how there's been an increase in training places for psychologists, and how we maybe want to look at stroke psychology as a specialism within itself, and promoting it as a specialism for people to come and work in. We've got Dr. Phil Yates talking about some recent documents from the BPS around workforce development and that. Alongside that, I was very fortunate to be a member of the Getting It Right First Time Leadership Academy, the first cohort with Deb Lowe and David Hargraves. So it's a privilege to be on there, and a plug for anybody who's thinking about doing it. Absolutely do. It's an incredible experience. Whether you're at the start of your leadership journey or whether you're well established, I would definitely give that a plug. But one of the things that came out of that, we were able to work on a QI project led by Carleen Scott on how we develop level 1 psychological care support within stroke services, and how we might develop a program, understand what the need is, and how we might develop a program that we could maybe roll out regionally, locally, but also nationally as well. And that's what we're presenting in our other session, is the results, the findings of that, what the consensus of what the level 1 support should look like, and how it might be delivered, and the best formats to deliver that, and how we might support it. And yeah, so we've got a session on that as well.
And Steve, just for my information really, what proportion of patients following a stroke do you think need that psychological intervention? You said that not a lot of people are aware of your role within the service, but it seems like there is a huge need there. What would you say is the proportion of patients that...
So the guidelines used to be, it was around 40% of people, stroke survivors, would need direct psychological input. You can look at kind of prevalence rates of mood disorder and cognitive disorder. I think acutely it's 100% really. There's some, it'd be perfectly understandable for people to go through a kind of traumatic shock response, and that would be completely, and that's a lot of what the acute level 1 stuff looks at, is normalising that and kind of working through that and supporting that is a normal reaction to suddenly finding yourself in a life-threatening situation in hospital. And cognitively, because of stroke, obviously it's an insult to the brain, there's going to be some kind of impact at some level. So understanding that and understanding what that means for engaging the care teams, engaging with the rehab that's on offer. So I'd say at that point it's about 100%. And that's why level 1 is so important. More community and more longer term, I think the evidence is around a third of people will develop some persistent mood disorder, which would need direct intervention, and around 75% of people will be left with some form of residual cognitive difficulties. So recognising that, I remember working with Nadina Lincoln a long time ago at the Uni of Nottingham, and saying that one of the most important parts of our role is not to send people home with unacknowledged cognitive difficulties that they're then confronted with when they get home. So understanding that acutely, but then having support in place more longer term. So I think it does, so the 40% I think is a kind of almost arbitrary figure. I think it changes over time through that recovery pathway. People's psychological needs, whether it's cognitive, whether it's emotional, changes. And the important thing is that we have kind of pathways in place to capture that, so that we know what support is needed when we can match the care at the appropriate time.
And you mentioned the kind of workforce development. Is there a kind of scarcity of those roles, or people filling those roles, particularly in the community setting when people are discharged from hospital? Do you think that's an area that...
So historically, there's not been enough psychologists working in stroke services. And I think there's many reasons for that. But one of those is that we just haven't had enough trained. And so with there being a substantial, significant increase in training places recently, which Kat will talk about, it's then about thinking about how we make stroke psychology an appealing career. And I mean, personally, I would very much kind of encourage people to come. But there's a kind of bit of scaffolding to that. In order to promote it as a career, we need to be able to offer the trainee places and show people, trainees, what we do, and we need to kind of have career structures in place so that it's worth people kind of taking that as a career approach.
And the services have to have roles available when, you know, to go into and really value that. And it's obviously built into the guidelines, but actually, you know, our service is very poor in psychology support, unfortunately. And going back to the training, you know, having the MDT trained to be able to identify and do some level of support is so important.
Yeah.
In order to manage, and, you know, without that, you know, and obviously, you know, we need to work towards having the psychology there, but also having the MDT trained to identify and signpost and do sort of some of the support where possible.
Yeah. Absolutely. And that kind of level 1 training to understand, be able to recognise And at the moment, just the way things are, we do have to be creative about how we deliver psychological support. And that level 1 training, the work that Carlene's doing in that project, I think is hugely important. As well as that, I think it's important that part of that level 1 training is about asking difficult questions that can be difficult about, for instance, suicidality, which is a scary thing to maybe start a conversation about, but a hugely important one. If we don't ask, people aren't afforded the opportunity to talk about what they're going through. But it can be scary for somebody just to ask that question, and knowing that there's support in place, that there's kind of the person on their own is that there's a safety net. And that's kind of where level 1 support can't sit on its own. There needs to be support in place for that. Yeah.
And actually, interestingly, I think some research coming out of, or some more focus, I think, from speech and language therapy, because of the awareness that people have who have communication difficulties after stroke, because they can't communicate how they're feeling. They're not always asked in the right way how they are, and we're not managing. So there's a lot more work looking at speech and language therapists sort of developing and almost taking some ownership of the kind of level 1, level 2 interventions for mood, for emotional support, for people with aphasia, and I think actually in the communication session, there's a session in aphasia in the conference that there's a speaker there who's looking at an intervention for people with aphasia for emotional impact. So that would be really, really useful to think about as well, because it's such an area that,
And even thinking about our patients we talked about who have swallowing problems and nutrition problems. Costas, you mentioned about people having it affecting their mental well-being. I mean, patients with swallowing problems and tube feeding, or not have access to normal food and drink is a huge risk on their mood as well. So, it's really important.
And it's all about, celebrating together, having a cup of tea is a good emotional support. 100%. If you can't do that, celebrating with your family or commiserating or I don't know, whatever. It's in so many different ways
it showcases the uniqueness of UK Stroke Forum, that you might go along as a speech and language therapist, but there's a whole MDT program. Let's go along to the psychology, let's learn some skills, let's find out about how people are experiencing having a tube long term in the community, because we might be based just in acute, and we lose that perspective, don't we? So for me, that's one of the unique things about the UK Stroke Forum, is so interprofessional, and everybody, you learn so much beyond, you get out of your silo and you learn so much beyond your own profession.
So Lisa, that's a great segue into my next question for all of you about what else are you looking forward to from UKSF? What are the sessions that you're really looking forward to that might be outside of your area of specialism, perhaps?
There's a lot to choose.
Yes. It's a packed program.
Really strategic with our time.
Yeah.
And have put like a timetable. So in the past, I know some of my colleagues in different units, they used to go out as an MDT. One person goes to this, other person goes to this, other person goes to this, and then they come together and do like a bit of a feedback when they go back to their unit of what they learned. Mm-hmm. Because there's a lot of sessions that are pretty much everything is very interesting.
Last year there's a catch-up. I don't know if that's happening this year, but if you miss sessions, you could catch up on the app, couldn't you? And that was kind of like you spend the day going to different sessions, then the evening catching up on the ones you missed. Yeah.
I mean, there's because I've got different hats. Sometimes I'm a clinician who's wanting to know what the latest thing I need to be doing is with my patients, and then sometimes I'm a lead. I need to think about what our service is providing, and then sometimes I'm also like kind of within the leadership role of strokes. I'm also thinking about how our service is running. So in terms of we're struggling, as everyone in the country is having enough medical team, for example, or having enough dietetic input into our service, or whatever it is, psychology, for example. So thinking about is there any other ways to do things, or can we structure our service differently? And then other hat on is, being involved in guideline writing and thinking what should we be recommending, what like dosage of therapy that people are providing, for example, and then others from a research point of view. So there's lots of so there's a few things there. So from a research point of view, I'm quite excited because I think there's more posters than we've ever had before, for abstracts for swallowing and difficulty. So that's really exciting, and it'd be lovely to try and find those people and link in with them, because we've got a network of post-stroke dysphagia researchers that we're trying to build that as a kind of network and support each other and strengthen that in the UK. And then, from a service level, there's a session around thinking differently about the role of the AHPs in terms of leadership within stroke services. So, for example, could we have AHPs leading on some parts of the stroke pathway that maybe will relieve the medical team to lead on other areas, because obviously we've lots of skills and experience and different skills to bring, potentially maybe rehab pathways, for example, so that from that point of view. So there's lots of sessions around research. In fact, you're involved in one of the research sessions.
I was going to put in a shameless plug for the research workshop, and that's really aimed at nurses and allied health professionals. It's ideas for getting into research if you want to get into research, but it's also encouraging staff to support research and to get involved in research trials. So not necessarily research that you're leading, but actually as a professional and a clinician in stroke care, getting involved in a trial and feel like you're making a difference because you're helping to recruit patients or identifying patients. So there's also a workshop looking at capacity assessment, which crosses all the divides, and it'll be looking at nutrition and decisions around capacity, people with cognitive problems. It's a huge area, not just people with communications. That's a nice MD focus. There's sessions on functional stroke, which I'm looking forward to. Post-stroke pneumonia from a medical viewpoint. That's really key for all of us, really, to be thinking about pneumonia, such a big thing, really, in stroke. There's sessions on co-design.
And also, as a clinician, there's an aphasia session looking at latest research. That's my way to kind of keep up with, I'm a speech therapist, but I very much know the research around dysphagia, but I have to find my ways to keep up with the aphasia research. So that's that way. And so that would be good for me to take back to my service as well. Yeah.
Provides a way to keep you updated. But I find these sort of conferences energise you. There's a bit of time to sit back and reflect about your service, reflect about policy development. Are we providing the best service? What's the evidence?
Come up with more questions for research. Yeah. I don't need any more in that book of questions, but yeah.
That's a huge part, isn't it, of the conference? It's not, obviously attending the sessions is the main part of it, but there is we were talking earlier about the importance of face-to-face communication, just being in a room and having those conversations that are just to one side. And the social element of the UKSF is hugely important, isn't it? From personal experience, we last year had an opportunity to catch up. We just put a call out if any of the psychologists were there, and we got together and didn't realise there were quite so many of us. And we from that developed spoke about earlier, the UK and Ireland Stroke Psychologist Network, and that's mushroomed, and it's been a really good opportunity to pull people together, not only from our own profession, but to kind of meet colleagues from different professions, just have those conversations, and then let your hair down at the social events on the Tuesday or the Wednesday. Absolutely.
So one thing that we've not touched on yet in this conversation is the huge psychological impact that a stroke can have on somebody. Steve, can I come to you just to talk a little bit more about the day-to-day role that you have and the need for psychological support for patients who have had a stroke?
Yeah, so thank you, Louise. Obviously, psychological support is highlighted in guidelines, and it's repeatedly highlighted as a need by stroke survivors. When you think about the impact of a stroke on someone's psychological well-being, we need to think really about what psychological well-being is. So when somebody's admitted into hospital with a life-threatening and life-changing event, obviously that's going to be traumatic, and it's going to affect that person significantly, thinking about the emotional impact of that. But it's important, I think, to recognise that from an individual perspective. So obviously some people may be worried about what this means for my recovery and what it means for my ability to engage in the things that mean to me, are important to me. Will I be able to get back to work? What does it mean for my role in my relationships with other people? All of those things are questioned at that point. And also, it's not only the bigger questions, but also the more personally relevant questions. So often speaking to someone on the ward, it's not only about does this mean for me and what am I going through, but it's also concern around who's feeding the cat at the moment, or can you make sure that my mail's kind of collected and those kind of things. So that's when we were talking earlier about the level 1 support. That's what it's really about, is recognising that we need to get to know that person, need to know that person as an individual and know what the stroke means for them. But of course, a stroke is more than just an emotional impact. It affects the brain, and it's an injury to the brain, an insult to the brain. So it's likely, and certainly acutely, to affect our thinking and memory, person's thinking and memory. So not only is that person trying to make sense of what's happened to them, but also thinking and memory may be affected, and that makes it more difficult to understand what we may be going through and why we're here and what's going on. So the psychological impact is far wider than just the emotional impact. It's the cognitive, and then also the behavioural. What does this mean for what I can do and for my recovery? So thinking about our day-to-day work as psychologists, it's about helping the person to understand for themselves what that means for them, what's going on for them individually, what that means for the wider team, about engagement in rehab, about engagement with medical support and the medical team. And then as we move through the recovery pathway, it's then thinking about what support will I need to go home. As I mentioned earlier, it's important that we don't send people home with unacknowledged cognitive difficulties. We need to think about what's this mean for the person's ability to make decisions and what support they might need to make decisions for themselves, and also what protection they might need as well. We then need to look at the ongoing impact of those things that we might have identified, cognitive difficulties, emotional difficulties, and think what support people might need along their recovery pathway. And then ultimately, as we look at discharging people from services, what this means for life after stroke, how I can live well, what cognitive difficulties I may be able to resolve, what I may need to compensate for, and what I may need to live well with, and thinking about what that means for living a meaningful and purposeful life, life after stroke.
Costas, anything that you're looking forward to outside of?
I would say I'm very much interested. I know sometimes there is a little bit of overlap sometimes between speech therapy and dietetics. So looking at the program, I think all the speech therapy sessions would be very interesting. From a personal perspective, I'm really interested in the quality of life, as I said, but also from an ethical consideration point of view when it comes in nutrition in stroke. So definitely the session around capacity assessments would be very interesting to attend.
And it's around just the shared decision making as well, rather than just kind of doing a capacity assessment. But again, it's within the guidelines. We should be enabling patients to be and supporting them to be able to be making decisions about their own care, and whether those are decisions that personally you might disagree with, but that's okay, because as if for example, deciding not to have a tube to feed them, and eating and drinking with some acknowledged risk around sort of getting pneumonia, or not meeting their nutritional needs, for example. But exactly, people should be able to sort of be given the information that they need to be able to decide, what do I want, how do I want my So that session is going to be great. And I've got a researcher, Dr. Mark Jays, who's done a lot of work in mental capacity, and then Alex Rooks-Keane, who is very experienced in capacity from the legal profession. So that'd be an interesting session. And I think there's also some patient involvement within many sessions.
Yes,
I think there's a real we do need to be listening to people. We've found the value of that in research. We have a group, public patient involvement group of people who have post-stroke swallowing difficulties, and they've been valuable in shaping our research questions, sometimes the methodology, sometimes the therapy, the intervention that I'm, the trial that I'm involved with. They have had some input into how the feedback, the biofeedback we talked about, how they want that feedback. So, really key. They're also in shaping services, which actually, like you mentioned, the co-design session, which I think is around, using people with lived experience or working with people with lived experience to help shape our services and our research. And
I think that's it, shaping the research and the services, isn't it? And really making sure that they have an impact on how things are.
And don't
going
forget,
forward.
there's also an opportunity to hear about the latest clinical trials and find out about trials, and it might be an opportunity for sites to think about signing up and becoming part of, the latest trials in their area. So there's always the late-breaking trial, the trials.
yeah.
So thank you everybody for your contribution today. I've really loved hearing about the different sessions that you're going to be involved in at UKSF, and it's really great to hear the multidisciplinary interaction in all of this work, and the fact that the conference is covering the whole stroke pathway, which I think is a really great step change and a good way forward for the conference. So I'm really looking forward to attending and hopefully attending all of your sessions when we're there. And hopefully people who have been listening and watching the podcast will also be excited to join us. And for anybody that's still thinking about joining, it's going to be held in Liverpool on the 3rd, 4th and 5th of December this year. So any more information that you want about the conference can be found online, and we really hope to see all of you there in December. Thank you.